Good evening, all, and welcome to my IVFenses. I'm glad that you are back with us. And as you can see, our special guest is right here with us as well, Dr. Halyna Strelko. You can see her right here. Hello, Dr. Halyna. I'm glad that you are back as well, and you have prepared one more case, and I'm sure that it's going to be interesting for all of our patients. So, thank you for joining. How are you feeling tonight? Hope you had a great, but I'm sure it was a busy day. So I'm glad that you are spending this evening with us. How are you feeling tonight?
Thank you. Fine, fine. Today we have 1st December and first snow in Ukraine.
Cool.
And I know that with the first snow we have the huge traffic.
Of
So
course.
I start at 7 o'clock in the morning to not be in this traffic. So all is fine.
I'm glad to hear that. And, I'm even more happy that you are back. And of course, I know it's a bit late for you. It's always the same, right? Because you are a bit,
Mhm.
the time is a bit different. So thank you so much indeed for joining us and for already presenting this. And I'm sure it's going to be interesting. And as you know, we will talk about Low Ovarian Reserve. And Dr. Halyna has prepared one definitely interesting case to show you. She will tell you all about this, of course, during her presentation, but afterwards. And I think it's always the most important part for all the patients is the Q&A session. And of course, she is right here to help you out with any questions that you might have. So prepare them, or if you have them ready, you can even type them in right now. So thank you everyone for joining as well. And I just want to mention my IVFenses is a part of European Fertility Society, and there are only 3 webinars left till our Christmas break, including this one. So I guess it's time for some summary. So thank you so much everyone for joining, because even from September, mid-September, we already have done 90 something, I think around 90 webinars. So it's been a great journey, especially that we were focusing only on success stories, different topics, but definitely we were focused on success stories. And Dr. Halyna was a part of few webinars with us. She presented few cases already. And it's amazing for me to see that the stories are more and more inspiring. And of course, your sharing and your questions are always something that bring. I think that sometimes, I think last time, yeah, Dr. Halyna, you did receive a question that you wanted to find out a bit more. You wanted to check. So that's what I want to say. That thank you so much for making this also interesting and also for being so thorough and in detail. This is always amazing to see, and that you are all engaged. And yeah, that is it from me at this point. I believe we can start off with our presentation. I'm already looking forward to see what Dr. Halyna is going to present, of course. Okay, ready?
Yeah, me.
Thank
Yeah.
you so much. Then let's go.
Thank you. Thank you. So, good evening, and thank you once more for your kind attention and for your time. And today we will talking about poor prognosis patients. We have talking about poor responders and late reproductive age, and both finally it is poor prognosis patients. Today I have as for me quite interesting case, and try to show you probably one of the possible approach for such cases. Uh, so mm, our new patients, our new patient for this evening named Tatiana. She's 38 years old. She came to our clinic in 2019, has in this moment one child born by natural way without IVF treatment. And after that, 2 years later, she tried to conceive a baby, has 5 pregnancies, 5 early spontaneous abortions. After that, she has done 2 IVF attempts in another clinic without success. About her previous IVF attempts, she said that first attempt was done in 2018, 8 oocytes, and only few embryos, 2 embryos, and she has done fresh embryo transfer, 72 hours, unfortunately negative result. Next attempt in the same clinic, a little bit less oocytes, only 5. Doctor decide to cultivate till blastocyst stage to see if probably no blastocyst, and really discover that no blastocyst. So she come to our clinic. We have done all examinations, and finally does not found something special. Ultrasound, poor responder, 2-3 antral follicles, low IMH level, but other parameters were absolutely normal. Infections negative, general analysis normal, coagulation tests are normal, hormonal tests are normal, so all is fine. Sperm count and motility normal. So we decide to try the protocol with what we call modified protocol. It means that we give anti-estrogens. In this case, we have done Letramara. It increase own FSH level, and plus to Letramara we give 150 units of urinary FSH per day. Because in FSH, urinary FSH, normally there is some LH activity, and for poor prognosis patients, it may give better response and better egg quality. And unfortunately, we receive not very good response. She give only 2 eggs. We fertilized these 2 eggs with ICSI. Fertilization was done, no problem, but we have no blastocyst as it was in previous clinic. So we try to investigate her husband, because probably it is something in sperm cell. We know that after 72 hours, activity of male genome is increased, so we should see if something wrong with sperm, and propose to do some profound examination, DNA fragmentation of sperm, fish of sperm, karyotype to herself and to husband, and found that DNA fragmentation is absolutely normal. The percentage of genetically abnormal sperm cell is in normal range, and nothing special also was found. So we try another stimulation, standard antagonist protocol with higher dose of urinary FSH, and the same response. We receive only 2 eggs, and we fertilize these eggs. After that, we discussed that probably there is some cytoplasmic factor, and we can try to improve the chance to this nucleus if we put them in donor cytoplasm. And in this case, we propose to patient to do what we call pronuclear transfer, and after that, at the same time, we start the stimulation of egg donor, fertilized donor eggs. After, I will explain a little bit more about the technical aspect of pronuclear transfer. We have done this pronuclear transfer, and we receive much better result in our cultivation protocol. You can see that we have good fertilization, but it was previously, and then we have good development of embryo, and at the end we receive good quality blastocyst. Blastocyst was sent to genetic examination, and we receive 1 healthy girl. Patient was prepared to cryotransfer, Standard protocol, 6 milligrams of estrogens and micronized progesterone, 600 milligrams. We has done the transfer and we receive good viable pregnancy. Now it is pregnancy not yet finished with delivery, but pregnancy developing well. So why we decide to do this pronuclear transfer? It is, how to say, poor responder. It is rather will be good to try to increase the number of eggs. But from the other hand, all the time this patient has embryo development arrest. Why it may happen? We know that the percentage of aneuploidy increase with the age of woman. But the source of this aneuploidy, not only maternal. We can see that percentage of maternal origin increase with the age, but also we have some paternal meiotic problem and mitotic problem. And if we analyze the percentage of this other problem in genetic abnormality of embryo, we can see that around 40% of this abnormality not related directly with nucleus of egg. It arrived later when embryo developing. So probably there are some other parts in egg inside of cytoplasm which may influence final embryo quality. We know that poor egg quality is one of the main causes of repeated failure in assisted reproductive treatment. The quality of the egg is mainly determined by small organelles named mitochondria. This is the little organelle which produce energy for the egg, for the cells. So if we have some problem with mitochondria, we will also have embryo development arrest, poor quality, poor fertilization, and so on. We know that a low concentration of mitochondria were found in patients with low ovarian reserve, approximately 2-3 times less than in patients with good ovarian reserve, and also in patients with who have late reproductive age. Mitochondria take part in the most of intracellular events. It means that the activity, normal activity of mitochondria need for normal fertilization, normal cleavage, also apoptosis regulation, and embryo development. And low mitochondrial level in oocyte may decrease the infertility treatment result, as we know. We also know that mitochondria is mostly provided from oocyte. Mitochondria from sperm cell is quickly degraded, and that's why we can take mitochondria mostly from eggs. The role of mitochondria during aging shown in this slide, and you can see that during the life we have what we call free radicals, active oxygen radicals, and they may destroy somehow mitochondria, and it produces the point of mutation in mitochondria, and with the aging the processes of cell death activated. We also know that mitochondria, it is like power plant of oocyte. This energy is produced by mitochondria called ATF molecule, and it is the main source of energy of cell. We know that it was shown in a lot of scientific works that amount of mitochondrial ADN is related with the age of woman and decrease dramatically. Amount of mitochondrial ADN is related to fertilization rate and with aneuploidy rate, and also related to possibility to implantation. So we can see that the main cytoplasmic factor of oocyte probably is mitochondria, and when mitochondria does not work in well, or the quantity of mitochondria is not enough, we can constate the very poor prognosis. So what we can do and how we can donate this mitochondria, increase the number inside of cell? Mostly by three different ways. Spindle transfer. Spindle, it is the nucleus which is put in donor cytoplasm. Pronuclear transfer, when we fertilize egg and then put in donor cytoplasm. And also there is a technique named augment. We take mitochondria and put inside of oocyte, but this technique is quite how to say, the effectiveness of this technique is not proved by some scientific works. What is the indication for mitochondria donation? Finally, it is the same indication as we said at the beginning. This is decreased ovarian reserve, because in most of cases we have low mitochondria number, advanced maternal age, some PCOS patients with poor quality of oocytes, some genetic factors, endometriosis, and mitochondrial disease. So, from technical point of view, pronuclear transfer, you can see here, we should do fertilization of woman egg and of donor egg. Donor egg should be fresh, should not be frozen, and woman egg may be frozen. Not egg, but pronuclear stage. Because free cytoplasm of donor should be, how to say, fresh and not damaged by cryopreserving methods. So we fertilize at the same time woman and donor egg, waiting for the stage of pronucleus formation, and the next day we take off pronucleus from the woman egg and put in the empty cytoplasm of donor egg, and pronucleus from donor egg is taken out. So in this scheme you can see how it is, and also you can see the leaf photo how it is on the microscope. This is the photo from our laboratory. You can see two pronucleus in this photo, and you can see how embryologists with the pipette take out this pronucleus and then will put them inside of donor cytoplasm. And I would like probably to ask the help of Caroline to move the slide, to move next slide. Thank you. And we have done quite a lot of cases. We have now 38 patients. Total number of oocytes which were reconstructed with this technique is 177. It is a big number. We have quite nice blastulation rate, and with pronuclear transfer even we have better blastulation, 74%. With spindle transfer a little bit less, 67, but anyway it is a good percentage. Number of embryo transfer patients, now it is 18. Number of clinical pregnancies, 9. Number of live births is 4, and we have still 5 ongoing pregnancy. We are waiting for the delivery. So we have quite nice experience with this technique, and in absolutely most of case, it is done to patients after 4, 5, 6 attempts with very poor embryo quality, with embryo arrest, and they try a lot of things and does not work. So this is really poor prognosis patients. Can we go forward, Caroline? Thank you. So, if we are talking about future fertility treatment, probably it will be the standard technique, the different kind of mitochondria donation, like spindle transfer, pronuclear transfer, transfer of donor or autolog mitochondria. Also, very interesting direction is stem cell activation, formation of new oocytes. Okay, a lot of works now in the world, but from practical point of view, not such a lot of successful results. Also interesting direction is regulation of antral follicle atresia. And we try to do that for some patients, giving them replacement hormonal therapy. And in some case, in 2-3 months, we can see a couple of little follicles, and it may be also sometimes helpful. But of course, there are another method of regulation of antral follicle atresia. A lot of works about anti-Mullerian hormones, so probably in a couple of years we will see the new directions and new possibilities. And also interesting branch is formation of eggs and sperm from somatic cells. And also there are some promising publications. Probably in a couple of years we will be able to do that as well. So next slide. Thank you very much for your kind attention, and I will be ready to answer all your questions. And thank you, Caroline, for your help. Something wrong with my pointer. I cannot move the last slide.
Hi, can you hear me right now?
Yeah.
Okay, sorry, I had a bit of a problem, but it's fixed now. I'm glad that you can hear me. Thank you so much indeed, of course, for providing this. This is definitely an interesting case, and also thank you for explaining, because this is something definitely new still, because of course this is not possible to do everywhere. So thank you for bringing this, definitely, Dr. Halyna, and there are some questions, of course, right here. And remember that we are right here for you. So even if you have some other questions, as I've mentioned earlier in the chat section, you can go ahead and type those in, okay? Dr. Halyna is right here for you to help you out with any questions that you might have, of course, okay? So let's have a look, okay? As I've mentioned, there are some questions ready. And of course, the first one, I already said that it's possible definitely to get in touch with Dr. Halyna and her team at IVMED, and I'm sure they will be more than happy to help you out. Okay, there is, as I mentioned, there is a link you can use. Perhaps just to make sure, Dr. Halyna, if there is like an email you can provide to anyone that would like to get in touch, that would be great.
Yeah, no problem. I will send you my mail, or you can write to Caroline, and also
Exactly. And we would be happy to forward any questions that you might have, like detailed ones, anything that that you would like to share, and we would be happy to simply forward this. And I'm sure the team, IVMED team, and of course Dr. Halyna will be able to help you out. Okay, just to clarify, that was the first question, but of course let's have a look. There are more questions coming up. Thank you so much, Dr. Halyna and my vivances. Is it possible to work with my eggs and with donor eggs in the same IVF cycle? I'm 40 and my MHE is 0.83. I had a failed IVF cycle with my own eggs. We got 7 eggs and implanted 2 day 3 embryos, but without any luck. Also, it seems that IVF clinics in Europe are far more advanced than those in the US. Anything you can help with?
Yeah, good question. Thank you very much for your question. The main indication for pronuclear transfer is not very late reproductive age, like 45, 46. Age better to have before 42, 43. And so you have 40, it's okay. IMH level is quite good, so we can expect to receive 6, 7, 8 eggs. We can do even 2 stimulation in one cycle and receive more eggs. Normally, we are doing like that. We stimulate woman, uh, receive eggs, fertilized, and freeze in pronucleus stage. We can do at the same time egg donor stimulation, but it is not mandatory exactly the same day. We can do it a little bit later when we have all our pronucleus, and then decide that it is the time to do an embryo. Because for this technique, first moment that we should have very good quality donor eggs. It is not important the phenotype of this donor, because mostly genetic material go from the parents, but quality of eggs should be good. And second point, that embryologists should have time for this technique, and it should not be very busy day, so we plan to more quiet and more, how to say, not relaxed, but more to have more time for this method. And of course, we can do that during one menstrual cycle, 1 or 2 stimulation, and egg donor pick up a little bit later than your pickup. And then we were doing this technique and then waiting for blastocyst formation. And normally, in most of cases, we are doing NGS diagnostic to be sure that genetic is correct.
Excellent. Thank you so much for sharing. And I know that
So
you've been here with
probably
us before. So thank you so much for coming back to us, and of course for your question. And actually, before I go to the next question, to our next question from the patient, another patient, let me go to this, okay, straight away. Thank you so much. Mitochondrial donation is the future of IVF. What is the cost of this treatment? And can patients from the US come to your clinic to request this treatment after 1 or 2 failed IVF treatments? Thank you so much.
Thank you so much for your question. Of course, we have no legal restriction. It is probably not so good, probably good, but in Ukraine, there is no very strict legal issue related to IVF treatment. A lot of things not prohibit, so we can do them. They are not described, so this technique is not described, so we can do that, and there is no restriction that we should do only after 5 attempts or 6 attempts or something like that. So we can do even without attempts, but the indication to do that and the real need to do that, if we have for example, arrest of development. We have fertilization, but after 72 hours or 96 hours, embryo does not arrive to blastocyst stage. So this is one of the best indication for this technique. And in most of such cases, we receive the beta blastulation after pronuclear transfer. What about the cost? It is much less than in the United States. I will give my mail to Caroline. She has, so you can write me. I will write you all details about financial issue, and of course you can come, and we will be happy to help you.
Of course, thank you so much. Indeed, I'll be more than happy to. So just send me an email, okay? You will get this, of course, and I'll be more than happy to forward this. And I'm sure that Halyna and anyone that I've been there will be able to help you out with all the costs involved as well. Okay, thank you so much. And let's have a look. Next question is up from Camille. What is a disadvantage of the pronuclear transfer method?
Great question. Thank you. This is a really good question for us also because, okay, it is still experimental. You have seen that from the one side, we have done quite a lot of pronuclear transfer and spindle transfer, but from the other hand, it is not thousands. So we have no give the big statistic about possible problem. Now we don't see a lot of problem with this technique and disadvantages. The main disadvantage, as for me, that we never know if this technique will be really helpful or probably will not change a lot. If the main problem is inside of nucleus of woman egg, of course, this technique probably will not be so helpful because nucleus will still the same, and we have no possibility to do some analysis or something to know that before. So we should try and see if it will be helpful. So this is probably the main disadvantage, that we cannot exactly predict that in such exact case it will work or will not work. But the main indication, it is poor egg quality, but still egg should fertilize, and late reproductive age, but not very late. And we should have as minimum 2, 3, 4 eggs to have something for pronuclear transfer.
Wonderful. Thank you so much, Camille, for your question. Thank you for the explanation. Definitely interesting. Okay, next question. In pronuclear transfer, the recipient oocyte has only one polar body instead of two. Can it be a problem?
Still, we have no such problem. Um but our embryologists choose the best eggs which are correctly fertilized, and even sometimes they are doing they put a fertilized donor nucleus in cytoplasm of patients, so doing like just opposite, and it permits to see if this donor nucleus inside of patient cytoplasm after arrest not give blastocyst and normal pronuclear transfer give. It means that really this patient have cytoplasmic problem and not nuclear problem. But still we can only see that after we has done this technique, not before.
Okay, thank you so much once again for yet another question. And now let's go to the next question. What is the difference? Because still, I think it's quite kind of confusing as well for some people. So between egg donation and mitochondrial donation.
Okay, thank you for this question. I try to explain the egg donation. We take egg of another woman, put inside sperm cell of husband of this woman who would like to become pregnant, and we receive embryo containing genetic material of husband but not containing genetic material of wife. But after we put this embryo in the uterus of wife, and she became pregnant, but genetically there is no relation with this baby. Yeah, this is the pure egg donation. The mitochondria donation all this technique of pronuclear spindle transfer we can call mitochondria donation. Pure mitochondria donation, it is in other things, but what we are talking now about, it is pronuclear transfer. So it is a little bit different. We take nucleus, fertilized nucleus from own cytoplasm, from own eggs, and put in empty donor cytoplasm. It means that genetic material is still woman and man, husband and wife, and only little amount of mitochondria ADN is inside of this egg and future embryo. So genetically, future baby will have a relation with their parents, and not only men, like in pure egg donation. Pure mitochondria donation, we fertilized egg, or not fertilized, put previously some amount of mitochondria, own or from another egg, and also cytoplasm and nucleus is the same, related to woman. So it is not egg donation, it is some reconstruction technique, but genetically it is from husband and wife material.
Thank you so much for the clarification, and thank you for your question, because as I mentioned, I think this is still something that not everyone is quite aware, and I'm glad that we are able to talk about this. And of course, thank you for
Yeah, it
your
is difficult. It is really difficult, and
yes.
I understand that. And probably me as gynecologist does not explain so well. I try, but
Definitely clear now, so don't worry. I think it's definitely clear now. So, thank you so much. And well, there is only this I can show you. Thank you for your answer, and great. So, thanks a lot, of course.
thank you.
And let's have a look. Okay, another question is right here. I'm 42, have premature ovarian failure. I'm wondering, I'm interested in embryo transfer as I have almost no period. How should the preparation for embryo looks like? I have I understand that it should take about a cycle and a half. First one to get period, and one then once endometrial tissue is ready, then the embryo can be transferred. Can you explain?
Yeah, thank you for your question. This question, if I understand well, related more to the uterus preparation to embryo transfer and not to try and pick up own eggs. So finally, period, it is important. In some cycles, we are using own follicles and own hormones of women for preparation. We can follow in the follicle growing and see when uterus will be ready for transfer and put embryo. But in most of cases, the cryo transfer is done without own hormones. So if you have no period, if you have no hormonal activity, normally we start with giving the replacement hormonal therapy. It is estradiol valerate or estradiol hemikidrat, normally in dosage of 6 or 8 milligram per day, or transdermal or peros, so different preparation we can use. And 7, 8, 9 days you will take that. After that we will measure in endometrium thickness and see the ultrasound picture of endometrium. Should be 3 laminar and should be more than 7, 8 millimeters. Will be better if your endometrium will be like 9, 10, 11 millimeters. As soon as we receive such thickness, we will add progesterone. Normally it is micronized progesterone like utrogestan, for example, and we give around 600 or 800 milligram per day. And after a couple of days, we are measuring your progesterone, plasmatic progesterone level, should be more than 10. And if we have such condition, after 5 days of progesterone, we will do the embryo transfer. And it is correspond to hormonal situation if you have ovulation and Your embryo became blastocyst and came in your uterus after 120 hours of development.
Thank you, Anna, for sharing. I believe that was useful. But of course, if you have any follow-ups, go ahead, type those in, okay? Dr. Halyna is right here to help you out as well. But I believe it has been already useful. And let's have a look, okay? Next question from Carla. I'm 40. I had an abortion last year. My MH is 0.2, FSH 8, made one IVF with one egg, no success. Tried natural cycle with letrozole, and there was the same result. My question is, should we try more cycles or get immediately to donor egg?
Very good question. Thank you very much. This is unfortunately quite often we have such a situation. It depends on egg quality. If we receive more or less good egg quality, even if it is one per cycle, or we can receive two, three if doing double stimulation in one cycle. Okay, we can try to receive more, to freezing couple of time eggs, then thawing one time, fertilize, cultivating, etc. Of course, it is time consuming. It is very difficult from emotional part, because okay, you are waiting, you try to do something. Sometimes it is ovulation, sometimes we have no eggs, sometimes egg is not so good, so it is difficult. But if it is time to time is possible to receive good quality egg, as for me, possible to try 2, 3, 4 months and try to receive 3, 4 additional oocytes and try to working with them. Of course, with egg donation, more quickly, more easy, and the result will be, how to say, much more quickly achieved. So after it is depends on your emotional and if you can waiting for that from that mostly.
Okay, thank you so much for your question indeed, and for your again answer recommendations. And Carla has one more question. Let's have a look. Okay, is there any supplements that we should take to improve better work of the mitochondria?
Yeah, very good question. Thank you. It is described a lot of supplements, for example, coenzyme Q10, also vitamin E, also replacement hormonal therapy, improve not directly mitochondria, but may help to have a little bit more follicles, a little bit more eggs in couple of cycles. Of course, it is difficult to have proof that these supplements directly improve mitochondria function, because okay, egg development lasts 12 weeks. It means that we should take 3 months, 6 months. But after that, if we take egg necessary to measuring something to say, okay, in this case, it is working better. But how we will do that? So it is described that there is a correlation after some kind of supplements, but difficult to say exactly and measuring in each case.
Understandable, perfectly, of course. But thank you so much for that question. I think it's always about supplements. It's never, it's hard to say that, this is definitely proof that it's working, etc. Yeah, this is
Yeah, this is the
the
question,
problem.
to have the
Yeah,
scientific proof that it is really working.
exactly. And well, at least at the moment, it looks like that might be our final question. So I always want to say that if you have more, you can still do it now. But if not, remember that it's always possible for you to get in touch with Dr. Halyna and her team at IVMED, and they will be more than happy to help you out. I have no doubt here. And that way, you can always get some more details, right? Because I know that doctors definitely require more details from you in order to give you a proper answer. So don't hesitate, okay? Don't hesitate to ask. And someone is typing, I want to see if it's another thank you, because there is one from Yana already, but possibly there is another question. Let's give it a second, Dr. Halyna. We need to wait and make sure. But if not, we will be finishing for tonight. However, I would like to thank everyone for joining us tonight. And this is, well, not a question, but yes, and it's all quite complicated. Couldn't agree more. This topic, this is definitely not an easy thing for sure. But I'm glad we are talking about this. That's for sure.
I agree that it is complicated. Even for us, it is complicated.
I'm glad that we are able to show that there are some alternatives because, as I mentioned, it's not used everywhere. It's still something new, but I think it's now important to talk about it and even show everyone that there is something that that maybe is possible for you. You never know, right? So thank you so much for that, Dr. Halyna, also for bringing this simply. And we will be finishing. So one more question though.
Mhm.
Do you know any facilities in Canada that offer the mitochondria donation?
I'm not sure, but I will try to search and give the answer through Caroline if we found some. I know that some clinic in Spain doing that. In United States, it is not viewed as probably due to legal issue, so it is quite complicated. So, okay, it is possible, but I cannot give you right now the exact address. I try to search and give the answer through Caroline.
Yes, let's do that for sure. Okay. It's hard to say, but of course we can always do that. I would be more than happy to get back to you, Ashley. So I will keep that in mind, okay? So we can get an answer because of course it's hard to say. And UK, maybe you know about UK.
Also the same, the main problem, the legal issue. So in a country with very strict reproductive law, as for example UK, it is quite complicated.
Okay.
So
Yeah.
in here is a spindle transfer, but as well I will see couple of address and
Mhm.
probably will give to Caroline if it will be helpful for you.
Sure, definitely. It's interesting, to know, of course. I can only imagine because, it's definitely a thing that not it's not possible everywhere. I'll be more than happy to forward this to you. So uh, okay, and there's of course thanks. Okay, one more question in the meantime. So I guess we can have a look. I had an image of 1.04 tested in 2020. I was planning to do IVF and got pregnant, and I got pregnant naturally. Now I'm 34. Unfortunately, I cannot carry a baby due to a hysterectomy. What can be the outcomes to try to do IVF?
Oh, he is very sorry for this issue with hysterectomy. Probably there was some bleeding or something like that. In this case, unfortunately, only one possibility is surrogacy. We can stimulate ovary, receive eggs fertilized with husband's sperm, create embryos, and then preparing the surrogate mother, put embryo to her uterus, and then she will carry the pregnancy. So, unfortunately, only this way. Also, there are some clinics, mostly in north of Europe. They try to do in uterus transplantation, but it is quite complicated, necessary to receive medication which depressed immunity. So as for me, the easier option is surrogacy.
Understood, of course. And I just want to confirm, and it is possible to do surrogacy in Ukraine. I'm not sure if you are performing this also at the clinic.
Yeah, it is possible. Also, law is quite simple for surrogacy. Husband and wife should be officially married. We cannot do for how to say, not official couple, only official, and only woman and man. not to men and not to women.
Okay.
And should be medical indication. It should be described in some medical document, like, for example, document certify that was done hysterectomy or something like that. And then should be official notary approved agreement with surrogate mother. And then from legal point of view, we can do that.
Okay. Of course, thank you for the clarification. Just wanted to make sure, but of course, thank you so much. I believe that was again helpful. And thank you everyone for your questions. And again, as you can see, Dr. Halyna, thanks a lot. Very interesting webinar. What can I say? It's the truth.
Yes.
Definitely interesting case. And I'm glad that we were able to talk about this experimental still, but of course, definitely promising method. And of course, again, as you can see, thank you. Very informative. So thank you so much. And before we finish, as always, I want to give you a chance if there's anything you would like to add. Dr. Halyna, anything you
Oh,
wish
sorry,
to?
sorry. Finally, I thank you very much to you for your help and to all people who stay with us during this hour and write this interesting question. I hope it was helpful for them. And if they have any other question, I am ready to answer. So probably they can write to you, Caroline, and after we will be in touch. Or I will answer to you, and you will
There
send.
is always a
So,
possibility. And
any
remember,
possibility is open. So with pleasure, we'll answer
exactly.
all the questions. And have a good evening, have a good night, and hope it was a little bit helpful and interesting for all participants.
I am sure you can see the comments here, right? So thank you so much indeed. And I just want to mention that yes, you can either contact me or actually after the webinar is over, you will be redirected to Dr. Halyna's profile on our site, but there is a contact button. And if you click on that and write your email there, put your details, there will be a possibility for you to simply get in touch with them directly. And I'm sure they will be able to get back to you, so don't hesitate. Definitely interesting session. So thank you so much, Dr. Halyna, not only for this webinar tonight, but for all the previous webinars. As I mentioned, we are slowly closing in when it comes to webinars of 2021. And of course, there will be more in 2022. So I'm already looking forward to some more webinars with you. Thank you so much for for you participating in those webinars, and of course for your support throughout all this project. So I'm always happy to cooperate anytime, really. So thank you so much. And everyone, as I mentioned, we will be back here tomorrow as well at 7 p.m. So don't hesitate to come and ask your questions. I'm sure you have plenty of questions. This webinar has been also recorded. You will have a chance to watch this, and you can have a look after we finish. You can have a look at the previous webinars with Dr. Halyna from IVMED. And thank you so much. Have a lovely evening, and Dr. Halyna, see you very soon. Have a great evening, and again, simply thank you so much.
Thank you for such
Thank you.
possibility to talking, to speaking, to explaining, to
We are
give.
always happy to listen to you. So thank you so much indeed. Thank you and take care. Have a good night. Bye bye.
Bye.